Hello, and welcome to part 2 of nuclear medicine thyroid scintigraphy. So today we're going to talk about nuclear medicine in thyroid cancer, and I'm going to divide our discussion on thyroid cancer into two parts. Today we'll talk about the various types of malignant disease which are encountered in the thyroid gland, and we'll also discuss how scintigraphy can be used in the evaluation of these. And in the next talk, we'll go through quite a lot of images and discuss the findings at scintigraphy. So, there's a wide variety of malignant tumours found in the thyroid gland. By far the commonest is a category called differentiated thyroid cancer, and that is composed of an amalgamation of the two commonest malignant tumours, papillary and follicular thyroid cancers. Now they're grouped together in a way which is quite helpful to us because both of these tumours can be imaged and treated by radioactive iodine. Anaplastic tumours are quite rare. They don't often present for radiological imaging because these patients often come with a locally advanced tumour with limited therapeutic options. So we don't see them that often, at least the de novo presentations of anaplastic tumours. Differentiated thyroid cancers are usually quite low-grade tumours at presentation, not all cases, but certainly a very large proportion of them are. But over time some of them can undergo dedifferentiation and they can become rather anaplastic in their histological nature. And that is a second type, if you like, of anaplastic tumour which you might see. This progression of differentiated thyroid cancer over time into a more anaplastic tumour is something that we will encounter and have to make allowances for in our imaging evaluations, and we'll discuss that more later. Medullary carcinoma of the thyroid, well, this isn't really part of the thyroid gland at all. In effect, it's a separate organ which just happens to reside in the same location. And for that reason, we cannot use, or we don't use radioactive iodine to evaluate and look for metastatic disease in medullary carcinomas. We have a completely different set of tracers which we can use to examine those. Lymphoma of the thyroid gland is quite rare. It usually presents as a diffuse symmetrical enlargement of the thyroid gland, and it's usually quite evident on imaging because at ultrasound, which will be the primary modality the patient usually is evaluated with, the gland will be of a very low echogenicity. In CT it may be infiltrating the adjacent vessels without compressing them, and there may be quite a lot of lymphadenopathy. So usually it occurs to us at presentation that the patient has lymphoma of the thyroid gland, and we'll do a core biopsy of that straight away and make the diagnosis. So it's rarely of diagnostic confusion, and the patient usually goes to the hematologist straight away for standard lymphoma treatments, and of course we don't use radioactive iodine to evaluate or treat these. I'm just going to mention Hürthle cell variants. These are just a subset of differentiated thyroid cancers which do not take up radioactive iodine, and therefore we cannot use that to look for metastatic disease. You can also see metastases in the thyroid gland, but they are not very common unless there is extensive metastatic disease elsewhere from a tumour, so they don't very often cause a diagnostic conundrum. So primary thyroid cancers are only 1% of malignant tumours, but especially in those centres which accept the patients for treatment, they can take a high burden on imaging resources. The patients are young and the tumours are often slow growing, so they may come back for many resections, both locally in the neck and of metastatic deposits or SABR radiotherapy treatments. They may have multiple radioactive iodine therapies and occasionally chemotherapy. So we often see the patients with us for a long time, over many years. We mentioned that differentiated thyroid cancer was divided into two types, papillary and follicular. Papillary carcinomas are generally better differentiated, and most microcarcinomas, which are very small tumours, are papillary and often seen incidentally at autopsy. And one thing which is rather beyond the scope of this talk is how aggressively should we be treating thyroid cancer. In practice, almost all thyroid cancers will be treated unless the patient has an underlying medical condition which would make it inappropriate to do so, but it's not clear to us how much we're actually prolonging the patient's life by and how much good we're actually doing them by treating some of these small, well-differentiated papillary tumours. They tend to spread first to the regional lymph nodes in the vast majority of cases. Follicular carcinomas, it's said that they are more likely to be blood-borne and spread to bone and lung, although of course we do often see them in the local lymph nodes as well. As we said, medullary carcinoma is completely unrelated to the differentiated thyroid tumours, and in effect it's a separate endocrine organ which just happens to be residing in the thyroid gland. And the tumour is one of the neuroendocrine cells of the neuroendocrine parafollicular cells in the thyroid gland. It's of some interest to us because it's associated with other diseases which are radiology intensive and which we should be looking out for: MEN2, von Hippel-Lindau disease, neurofibromatosis, and we should be aware it does present as a familial variant. And since medullary carcinoma is a relatively rare tumour, we should always be alert to the fact that, especially if a very young patient has it, that it could be a familial subtype. It spreads to lung, liver and bone, and it can present with paraneoplastic syndromes. I don't propose to talk too much more about medullary carcinoma here. We'll discuss it in a future series on neuroendocrine tumours, because the tracers which we use to evaluate medullary carcinoma are those which we use to evaluate neuroendocrine tumours elsewhere. Now, we do have to speak about the various tumour markers that are used in the evaluation of thyroid cancers and the monitoring of them, because they'll be very important if you want to have a meaningful conversation with the clinician and understand their clinical information. Differentiated thyroid cancers produce thyroglobulin. What is thyroglobulin? It's a precursor to thyroxine. It's a substance which undergoes chemical and enters a chemical pathway which results in the production of thyroxine through iodinification. So it will be present it's a very large component of the protein production of a normal thyroid gland, and many differentiated thyroid cancer cells continue to produce it. Once the thyroid gland has been eliminated from the patient's body, any thyroglobulin produced must be by cancer cells. So it's a very sensitive tumour marker. Unfortunately, 1 in 10 people produce anti-thyroglobulin antibodies, and somewhat more in patients with thyroid cancer. So that can reduce the thyroglobulin measurement, but we can measure the serum anti-thyroglobulin antibodies, so that can tell us if they are in fact present. Now, there's one more thing just to mention about thyroglobulin. Once we have performed a total thyroidectomy and used radioactive iodine to eliminate any remaining thyroid tissue, it can take 6 months for the thyroglobulin level to fall to 0. So we don't expect to be able to use it as a sensitive tumour marker immediately after thyroidectomy. Medullary carcinomas also have tumour markers, calcitonin and carcinoembryonic antigen. I'm just going to mention one more thing about these tumour markers. I did mention that differentiated thyroid cancers can become more anaplastic over time. That has significance with regard to thyroglobulin measurements. If the tumour becomes more differentiated, the thyroglobulin level may fall, so you may be under the misapprehension that your patient is actually responding to treatment. And you always have to keep that in mind and correlate with the imaging findings, because if the patient is demonstrating progressive metastatic disease on a CT scan, but their thyroglobulin is falling, then it might well be that the patient is developing a more anaplastic tumour. With medullary carcinomas, the calcitonin level can fall and the carcinoembryonic antigen level can rise. That can also indicate a dedifferentiation of the tumour. So I'm not going to talk anymore about medullary carcinoma. We're going to talk about differentiated thyroid tumours for the remainder of this talk. So why do we use iodine? Why do we use thyroid scintigraphy to manage patients with thyroid cancer? Well, there's two things we do. We're using iodine 131 as a therapeutic option in patients with thyroid cancer in ablation and therapy. I'll explain the difference between those in a minute. We're doing that to to confirm known disease sites for which we're giving the treatment, to identify any new disease sites, and to perform dosimetry. So what does all that mean? Well, if we're going to go to the trouble of giving the patient iodine 131 as a therapeutic option for its beta-emitting capabilities to damage and destroy tumour sites, then we might as well take advantage of its gamma emissions as well and perform scintigraphy on the patient. Because we're giving the patient a quite large dose to affect the treatment, and that means we'll get very good, high-quality diagnostic images. So it's a great chance for us to look for any sites of disease we might not know about, which is very important. It's also good to confirm that a known disease site took up the tracer. So maybe we gave the patient radioactive iodine for a lung metastasis. It's nice to see that the iodine arrived in the lung and was taken up by the target. Now, more sophisticated than that, we could perhaps perform dosimetry. Dosimetry is when we calculate the dose which has been achieved at the target tumour site. We're not sure exactly how accurate our dosimetry estimations are, but it's quite a hot topic and there's quite a lot of work going on it at the moment. If we're able to accurately identify how much treatment we've given to the tumour site, then that will help us to predict how much more we need to give the patient if we want to give them continued therapy for a metastatic deposit and allow us to tailor our dose appropriately. Now, we sometimes do diagnostic scintigraphy. That's usually with iodine 123 in order to identify metastatic disease in patients who are known to have differentiated thyroid cancer. So they may have an elevated thyroglobulin and they've been 2 or 3 years out perhaps, so we know that thyroglobulin measurement indicates tumour somewhere. We might want to look for the site of disease and we can do a whole body thyroid scintigram. We'll also be doing ultrasound and CT as well, perhaps to look for those disease sites, but this is just another option for us. So I said I'd explain the difference between ablative and therapeutic doses of iodine 131. Well, the standard treatment for patients with thyroid cancer is total thyroidectomy. After the total thyroidectomy, we give the patient an ablative radioactive iodine dose, usually 1.1 gigabecquerels. An ablative radioactive iodine dose is one which is given to patients immediately after their primary surgery in order to eliminate any remaining areas of normal thyroid tissue and make subsequent thyroglobulin measurements very sensitive. So if the patient was left with a tiny amount of thyroid tissue after their surgery, they might still produce some thyroglobulin normally, and that would make our tumour marker measurements a little less sensitive. So by giving this radioactive iodine ablative dose, we eliminate any last bits of normal thyroid tissue, and then we can use thyroglobulin as a very sensitive tumour marker, which is immensely valuable. In addition, we're hoping that our ablative dose will treat any micrometastases the patient may have. Finally, of course, it's a very useful diagnostic test, and we might be surprised to see metastatic disease that we didn't know was present. What's a therapeutic dose? That's usually higher, 3.7 or more gigabecquerels. That's given when we know the patient has a site of metastatic disease, or perhaps they have an elevated thyroglobulin and we know there's metastatic disease somewhere, but we just can't find it and decide to empirically treat them. So usually we will know there's a metastatic deposit on a CT scan, and we'll decide to treat that. That's a therapeutic dose. So it's important to understand the difference between ablative and therapeutic doses. Of course, they're both therapeutic in the literal sense, but it's customary to refer to them as ablative and therapeutic, just so we know, because they are encountered in different situations. So how are we involved? Where do we fit into thyroid cancer management? As I mentioned, the patient will have a total thyroidectomy. Then what we'll do is we'll just let them recover from that, and a couple of weeks later the patient will undergo that ablative dose of radioactive iodine to eliminate normal thyroid tissue, the final amounts of normal thyroid tissue, and hopefully treat micrometastases. At 6 months we can get a very sensitive thyroglobulin level, because now we should have all remaining thyroglobulin produced by the natural thyroid gland should have worn away, should have been metabolized. So a thyroglobulin level at 6 months should be very indicative of any underlying disease which is present, and hopefully will be zero. We also perform a neck ultrasound at 6 months. After that, the surveillance depends on the institution. I think some institutions may do routine thyroid scintigraphy, but in our institution you just have blood tests after that, and we only perform further imaging evaluations if your thyroglobulin is elevated or the patient returns with symptoms or signs are detected on clinical examination. If we do detect recurrence, then we can reevaluate the patient with ultrasound, CT, a diagnostic iodine scan, and then they can undergo multimodality therapy based on the results of those, with surgery, radioactive iodine, and occasionally chemotherapy. Just a few words about the Iodine 131 administration, because it's very good to have an understanding of this, because you'll be asked questions about these patients by your technologists. They'll be coming down through the department and you need to know what's going on with them. So usually the patient will be brought to a special room on the ward where these sort of treatments are administered, and they'll be given a pill containing the radioactive iodine. The patient stays in the isolation room until the activity in their body falls to an acceptable level. The vast majority of the tracer will be rapidly excreted through the urine. It is possible to treat the patients as outpatients, and some institutions do this, but you need to make sure the patient is very careful that they don't contaminate other people if that's the case. Once the activity has fallen to a certain level, they can undergo post-therapy scanning, and then they can be discharged. But it's very important we have that post-therapy scanning before the patient leaves the hospital for all the reasons I've described. Now, we of course one thing we have to do is we have to optimize the thyroid tissue and any metastases for iodine uptake. When we give the patient their therapy dose, or in fact a diagnostic dose of iodine 131 or iodine 123, we need to get that into the tumour. So we need to sensitize the thyroid gland to uptake of iodine. You can do that with a low iodine diet, which just as a rough guide would be avoiding seafood and also avoiding pink food colorings, which are for some reason high in iodine. You can do that and also raise the patient's TSH levels. Raised TSH levels are associated with increased uptake of iodine into thyroid cells, including thyroid tumor. So that's not a problem in patients who have just had a total thyroidectomy. We can just delay their thyroid replacement therapy, and that will allow their TSH to naturally rise, and we'll be able to do the scan. So it's not too much of a problem in patients who are having an ablative dose, but if we've just discovered, for example, a lung metastasis in a patient who's on thyroid replacement therapy, then we've got to in some way stimulate the patient's TSH in order to promote the radioactive iodine entry and retention into the tumour cells during the study. So there's two ways of doing that. The first thing we can do in the classic way is to withdraw the patient's thyroxine. So you can withdraw their T4 for 6 weeks, switch them to T3, and then you can stop that 2 weeks prior to the administration of radioactive iodine. That will render the patient hypothyroid, which is very unpleasant for them. 50% are unable to work in the week prior to the study, but it does give the best results, particularly for imaging. The problem is that it's not very nice to do that to the patient, and also some older patients and patients with underlying particularly cardiac conditions, that can be quite dangerous to interrupt their thyroxine treatment. So the alternative is to administer recombinant TSH thyrotropin to the patient. You give them 2 injections 48 hours prior to the scan, and that will artificially raise the patient's TSH. It's well tolerated, but some people say that it's not quite as good as the withdrawal method. It is, however, the thyrotropin, the recombinant artificial TSH, is approved for therapeutic doses up to 3.7 gigabecquerels. So it is certainly possible to give therapy doses with, and then perform, to give therapy doses where the patient has been prepared with thyrotropin, exogenous thyrotropin administration. Diagnostics Scintigraphy with Iodine 123. We can perform that at 5 hours and 24 hours after the administration of the Iodine 123. It's usually 400 megabecquerels. But of course we will have to prepare the patient just as we did for a therapy dose. You can use withdrawal or you can use recombinant TSH, although certainly some papers say that the image quality is less good with it's not as good with recombinant TSH administration when compared to thyroxine withdrawal. The final thing I'd just like to mention is IV contrast. IV contrast contains some free iodine, and for that reason due to the retention of this free iodine in the tissues, we try to avoid giving IV contrast to patients if we think that they might have a therapeutic dose of radioactive iodine in the near future. So you'll often see a request from a clinician in a patient with a query of thyroid cancer metastases, and they will write no contrast or no IV contrast on the request card. So that's the reason they're putting that on the request card, because we don't want to prejudice subsequent radioactive iodine therapy. Okay, so I think we've had a full talk here without any pictures at all, and that's because I just wanted to get through a lot of this theory about nuclear medicine in thyroid cancer, and in the next part we'll talk about we'll show quite a few pictures based on the discussion that we've just had. Thank you.